Today we are going to perform a bony amputation. It is also known as transfemoral amputation. First of all, we will mark the incision lines. Considering greater trochanter as our landmark and 17 centimeter below greater trochanter, we will go on the mid of thigh and mark the anterior flap lines and then posterior flap lines. After shaving the hairs with clippers, we will paint the whole leg or and the exposed area of thigh with povidone iodine 10% solution and then dripping with sterile sheets. The point where to cut the bone is shown here. It is just above the initial lines. Now we will first go on anterior medial of the thigh to create anterior skin flap. Here, now we'll go on anterolateral aspect and then posterolateral aspects of the thigh to create the posterior skin flap. The posterior skin flap is 2 centimeter more than the anterior flap. To create a skew flap, it is to use for the coverage of bone on the independent part, not on the dependent part. When making incisions through subcutaneous tissue, dissecting it, and now the fascia lata is being incised. It is the covering that is considered as a deep fascia of the thigh, encasing the whole compartments, anterior, posterior, and lateral compartments of the thigh. Here, anterior is considered. Now we are on the middle compartment. Here we will face the great saphenous nerve being lied in the subcutaneous tissue below the membranous layer of superficial fascia. Cutting off muscle is being done, also known as myotomy, of the anterior compartment. It contains sartorius, gracilis, ileus, vastus lateralis, vastus intermedius, and vastus medialis. Now we are going deeper down till the femur bone. The hemostasis skewering is an art, as it will clear your operating field. Make it sure by ligating the vessels or coagulating it with cautery. Here you can see we are now on the femur bone medial side containing neurovascular bundle. The neurovascular bundle is located in the adductor canal. Now we have separated the adductor canal from the neurovascular bundle. Skeletonization of the bundle is being done located on the medial side of femur bone. It is very necessary to completely ligate the femoral artery, femoral vein, and femoral nerve separately to prevent any future complications of fistula formation or leakage of any of the vessels. Palpation of the vessel is being done. The middle compartment contains adductor longus, adductor magnus, and adductor brevis. Sometimes gracilis is also considered as a part of it. It is supplied by obturator nerve and the branch of femoral artery, profunda femoris artery. It contains superficially the great saphenous vein, the great saphenous nerve, and the middle cutaneous nerve of thigh. Skeletonization is being done. You can appreciate it. We have made a tunnel through the facial layers of the neurovascular bundle. Artery is palpated and it is being ligated by a non-absorbable suture. We used silk. It is necessary to use a non-absorbable suture to prevent any future complications of being leakage and also slipping of the suture, and as it will lead to the secondary hemorrhage, which is most of the time considered as life threatening because it is a great artery, large side artery of the body. So it will flush whole of the blood from your body outside. We will assure the hemostasis and by securing the knots tightly so that blood flow is completely obstructed in the femoral artery. Now a branch of femoral artery is being ligated. It is very necessary to ligate all branches of the femoral artery. Assure complete ligation of all branches of the femoral artery, otherwise it will dribble down the blood and make your field wet, so it may hinder your procedure. The periosteum of bone is being elevated. Most of the time periosteum elevator is used. It is used to separate the periosteum from bone so that a bone is easily cut and no hindrance in the procedure come out. We have separated the periosteum and now we use the Gigle saw. It is used to cut the bone. People use bone cutter instead of it. Gigle saw is frequently available and it is also disposable, so you can use a new one. Assure that the distance between one and other part of the Gigle saw is at 90 degree. Bone has been cut and now we are on the medial compartment. Adductor longus, adductor magnus and adductor brevis are being cut down. Now the posterior compartment is being separated. Here we can appreciate the sciatic nerve. It will be cut as proximal as it has to prevent any neuroma formation. Neuroma formation will lead to chronic limb pain. Now the whole of leg that was infected had been separated and you can see a large posterior flap and small anterior flap. Myography of the muscles is done to cover the bone and the neurovascular bundle. Coverage of bone is very necessary, otherwise it will lead to osteonecrosis and also the friction or pressure necrosis of the overlying part of skin. Skewing of hemostasis at the end of procedure is very necessary, otherwise it will lead to changes in the dressing and also the patient will be uncomfortable and the surgeon as usual is uncomfortable by the soaking of dressings. The myography is done in two layers to completely obscure the bone. Facial data is being ligated at the end of procedure to make the compartment closely fit under your skin so that flaps coverage is sufficient. Skin is closed only when it is needed, otherwise it is left open in infected cases.